Welcome to another Francisca tumor board. Great to have a world-renowned faculty to discuss these cases. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and a thoracic medical oncologist. And again, joined by a wonderful group of faculty. I'm going to allow them to introduce themselves. We'll start with Dr. Bala.
I'm Sanjeev Bala. I run the cardiothoracic imaging section here at Washington University in St. Louis. It's good to be here.
My name's Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and Professor and Director Emeritus of the Winship Cancer Institute of Emory University.
I'm Varun Puri. I'm a thoracic surgeon and professor of surgery at the Washington University in St. Louis, along with Dr. Bala.
I'm Ross Camage. I'm the Director of Thoracic Oncology at the University of Colorado. I'm a medical oncologist and delighted to be here again.
This is a 72-year-old never smoker with a history of stage 4 adenosquamous carcinoma of the left lung with bone metastases, currently on capmatinib, high PD-L1, with some MET and I would say EGFR amplification positivity. The question that we're going to try to answer is what is the next step in treatment, including chemotherapy and immunotherapy? So this is a 72-year-old never smoker presented with shortness of breath, cough, and weight loss over 30 pounds in 6 months. Has a performance status ECOG 1. His medical history includes hypertension, hyperlipidemia, diabetes, glomerulonephritis. His social history, he's a never smoker, no drug or alcohol use. He's a retired construction worker, and he's got no family history of malignancy. I will let Dr. Bala go ahead and just interpret the CAT scan that we see here.
Thank you, Dr. Levy. So in the left upper lobe, there's a large mass that's somewhat irregular, and we can see that there's extension going to the pleural surface and involving the fissure. And if you look at the fissure, you can see that there are these small nodules. That's incredibly helpful because these radiating septal lines can occasionally be seen from a focal edema if there's venous involvement. But when you see those tiny nodules, it's very characteristic of lymphangitic carcinomatosis. And so it's helpful for making that distinction. So we've got this large mass, which seems to be involving the fissure and the pleura with this focal lymphangitic carcinomatosis. What's not shown is that there are also multiple lucent bone lesions, and there was also left hilar lymphadenopathy.
Okay. So it looks like based on the CAT scan, stage 4 disease with the bone mets and the lymphangitic carcinomatosis. So this patient, there's a CAT scan. Patient's admitted for presumed lung cancer, no biopsy yet, but certainly on presentation also had an electrolyte imbalance with hyponatremia and hypercalcemia. The sodium was 125, the calcium was 12.4, potassium 6.1. Found to have multiple bone metastases on full CT scan imaging, CT chest, abdomen, pelvis, treated with pamidronate to drive down the calcium. The brain MRI was negative. The patient has a CT-guided left lung biopsy that is consistent with an adenosquamous carcinoma. Most of the cells are positive for P63, P40. There's a small focus of cells positive for TTF1 and napsin-A, negative for CK20. And the PD-L1 came back at 60 to 70%. There was a plasma genotyping that occurred while in the hospital, and the patient did have a MET Exon 14 skipping mutation, and I'm showing you the summary of the associated FDA therapies that we see on the plasma genotyping report. Also noted was EGFR medium amplification and a P53 as well. Again, this is the 3 alterations that were discovered on the plasma genotyping. The patient eventually was discharged and had a PET scan. I don't think we have the PET scan. If we do, I'll let Dr. Bala review it, but it did confirm the left upper lobe mass and diffuse axial and appendicular skeletal involvement. The patient was started on capmatinib 400 milligrams twice a day, has improvement in cough and shortness of breath within 2 weeks. Has a tissue analysis finally done and completed, and the BRAF, EGFR, and KRAS were not detected, but the MET Exon 14 skipping mutation was confirmed in tissue. This oftentimes occurs where we get the plasma result first and then confirmed by tissue later. So Dr. Bali, let's talk about this as just a sort of an assessment while the patient was on capmatinib from July 2020 to October 2020. And again, the arrow represents the patient being on the MET-directed therapy.
Thank you again, Dr. Levy. Yeah, we can see that over this time period from July to October, there's been a dramatic reduction in size of that central mass. It's now kind of a smaller central nodule, and even the nodularity along the fissural surface has reduced, and the spiculations extending to the chest walls. So clearly an improvement in what we started with that both would be quantifiable and qualitative in seeing that change.
Okay. So clearly having a nice response and clinically having a nice response to capmatinib. Unfortunately, so that was October 2020, and that's 6 months later, a CAT scan in March 2021 shows definitive progression. We don't have images here. And in the lungs and the bone, the patient is complaining of much worse bone pain, more shortness of breath, so some clinical deterioration as well. Again, the plasma genotyping is interesting. The MET amplification did go up in variant allele frequency. It was originally, I believe, at 20. It's now 50%. And then the patient also has these other MET mutations, these acquired secondary mutations that at least has some preclinical data for cabozantinib. The patient also has an EGFR amplification that's gone up as well. And the P53 retained as well. So this is a heavy MET-onc question here. So I'm gonna lean on Dr. Kamich quite a bit, given he's a medical oncologist, but also has been leading a lot of this efforts in the world of MET globally. So Dr. Kamich, maybe back up a little bit and we can talk about optimal ways or ways that you manage patients with MET exon 14 skipping. Is capmatinib the drug that you usually use? There are others, one that's FDA approved, tepotinib. And then secondly, what you do with this liquid biopsy report, and does it make sense to trigger a therapy based on some preclinical data if it's sound? So I'll let you start with just optimal ways to manage this patient, or your impressions of this patient, and the ways that you would offer therapy and for patients with MET exon 14 skipping.
Thank you, Dr. Levy. I mean, clearly MET exon 14 skipping is a work in progress. There's something like more than 100 different mutations scattered throughout the exons and introns that can produce the end result of losing exon 14. And what is exon 14? Well, it's the region of the MET protein that codes for the Sybil binding domain, which is essentially the site for ubiquitination, which is the expiry date of the protein. So if you get rid of that, the protein hangs around longer, accumulates on the surface, and starts signaling. And D1010N is one example of that. So that all fits perfectly. We know that the response rate to the current licensed, what's called class 1 MET inhibitors, capmatinib, tepotinib, crizotinib, is only about sort of 40 to 50% in general. There's a small data set that suggests it may be a little higher in the first line setting, but that's not uniformly accepted across the different drugs. And so even amongst those people, there's clearly some heterogeneity. The great thing here is this patient fell into the responding category, everything's doing fine, but then they develop progression. So as with any targeted therapy, the first question we're going to ask is this oligoprogression or polyprogression? So one would like to see, a PET scan or something showing whether this could be something I could involve Dr. Curran to help ablate progressive clones. If it's much more widespread, we then get into the question as to whether we can figure out the biology. Some of the mutations you can see here are on-site mutations. D1228N is well recognized as a kinase domain mutation, which prevents the binding of the class 1 inhibitors. Now, the trouble is there aren't actually any licensed class 2 inhibitors which can overcome it. Cabozantinib is sitting in the pharmacy for other reasons and can work, but it can be a relatively tough drug to give. However, you could try it in this patient. If that doesn't work, and there's nothing else in clinical trials that you could try, as a small aside, MET-directed therapies in clinical trials will include people trying to develop more potent class 2 specific MET inhibitors, but also MET-directed antibodies. Now, they may include amivantamab is being explored. They may include antibody drug conjugates such as ABV399. There are even MET bispecific antibodies with 2 different epitopes that are being explored. And these could all be looked at here. If all of that fails, then you are now at the point where you're thinking about cytotoxic chemotherapy with all of the caveats about this patient's comorbidities. And there the question is, are you going to give something like carboplatin, pemetrexed, and keep the capmatinib going? Or are you going to throw the TKI over your shoulder and give carboplatin, pemetrexed, and immunotherapy? The patient has high PD-L1, and yet they are a never smoker, and probably that high PD-L1 means less in a never smoker with a proven driver oncogene. If it was me, I would add in the chemotherapy and keep the immunotherapy in reserve.
Excellent overview, and such a controversial area, and just a blitz of new therapies coming down the pike right now. Just some thoughts, Dr. Kamich, do you repeat a liquid biopsy or tissue biopsy in patients that develop disease progression on genotype-directed therapies? Is this your practice to do this, or are you just using one or the other, or none at all, when patients have disease progression, and not just oligoprogression, but systemic progression, where you're really thinking and warranting a potential therapeutic switch?
So the short answer is yes. For a period of time, this was just for research purposes, but I think increasingly we are seeing so many different options either available in clinical trials that you could rationally send your patient to, or we're seeing the activation of other oncogenic pathways. These things that we used to think were mutually exclusive can now come in the best supporting actor role, and you can jerry-rig combinations of different drugs, and certainly that has worked in my hands too. So I do believe that rebiopsy, broad reanalysis is the future. If you send off blood, which is convenient, and you don't find a rational mechanism, then you should biopsy tissue.
Dr. Kamich, I think that's an excellent overview. It sounds like for this patient, one would be to consider chemotherapy and continue the capmatinib, saving the IO for a later time, and potentially consider doing a liquid biopsy on this patient if there is systemic progression. Did I get that right?
Yeah, I don't know if I'm really just saying save the immunotherapy. I think the issue is there is a fork in the road where we don't have much data, which is, do you just throw the kitchen sink at the patient with chemo IO? They do have that high PD-L1, but they were a never smoker, versus the value of keeping the TKI going, particularly if some of the disease is still suppressed, where you don't tend to include it with the IO because of concerns about toxicity. So everybody's right and everybody's wrong. I tend to be in the latter category, keeping the TKI going, especially if there's evidence of ongoing benefit in some sites of disease.
So for the sake of time, we're going to move on to the next case. This is a 68-year-old female, current smoker, 60-pack year history with newly diagnosed stage 4 adenosquamous lung cancer with bone and brain metastases. The PD-L1 is 60%. Next generation sequencing notable for a KRAS G12D, STK11, P53, and KEAP1 alteration. Question we'll try to answer: what is the best recommended systemic treatment? And two, what other treatment modalities would be recommended, if any? We'll start with just the imaging here. This patient presents with potential cough and weight loss, and I'll let Dr. Bala review the CAT scan, some images from a PET scan, as well as the brain MRI.
Thank you, Dr. Levy. So we can see that there's a central spiculated mass in the right upper lobe on the lung windows, which is on the right upper image. It looks like there's also probably some hilar lymphadenopathy. On the PET CT, there's uptake, unfortunately, in this lytic lesion in the left iliac in keeping with a bone metastasis. And then in the brain MR, which is performed after the use of intravenous gadolinium, there's a focus of increased enhancement in the left aspect of the cerebellum in keeping with metastasis to the brain.
Okay, thank you for that overview of the imaging. So the question here is, and we'll go back to the original case. So this patient clearly, based on the imaging, has stage 4 disease, has an isolated brain met with a lung lesion as well as bone disease. PD-L1 is 60%. And again, some next generation sequencing, unfortunately not a KRAS G12C, but G12D. And then this STK11 and KEAP1 story. I'm actually going to throw this out first. Let's say this patient is extremely fit, and clearly this is another stage 4 patient where we're going to rely on Dr. Capmatinib to kind of walk us through what he would do. But Dr. Curran, let's first start controversial here. Let's just say that this patient only had 3 sites of disease: a brain lesion, a bone lesion, and a lung lesion with some adjacent adenopathy. Is there a role for local ablative therapy? Is this oligometastatic disease, or is there a consideration partnering with the medical oncologist to radiate all sites of disease?
Yeah, great question. And this is actually, Dr. Levy, an area of great discussion as well as investigation. We know as it relates to metastases in the brain, that even in the presence of multiple other metastases, brain radiation is frequently used early on in the management of patients with metastatic lung cancer to either manage symptoms or prevent progression in what sometimes is sanctuary to systemic therapy. In this particular case, assuming that cerebellar lesion is the only lesion, fairly small, it's peripheral, doesn't appear to have a lot of peritumoral edema, that does not look like that requires immediate attention if there's any argument that can be made to initiate therapy. In a particular patient, we don't hear about the symptoms, but pelvic bony looks significant. Would not surprise me if this patient presented with hip pain or low back pain, and palliation of that might be appropriate as well. But the broader question, and that is patients with low volume oligometastatic disease, is there a role that leads to better progression-free survival or survival when you combine SBRT or stereotactic radiation to multiple sites in conjunction with systemic therapy? My view as of 2021 is that really varies on a patient-by-patient basis. This patient doesn't appear to be an ideal candidate for that, but there are patients with low volume disease, high level of fitness, where I think giving single fraction SBRT before systemic therapy is very reasonable.
Okay, so Dr. Capmatinib, this is not an uncommon scenario that we see. This is sort of our wheelhouse. Stage 4 patient, PD-L1 60%, current smoker, has some co-alterations in their NGS that would potentially suggest, based on what data you look at, that maybe that there's some immunosuppressive activity going on with these alterations that may not make this tumor so susceptible to immunotherapeutic approaches, at least a single agent. But curious to get your take how you would manage this patient systemically if they showed up in your office.
I think your phraseology was perfect there. I think we recognize that there is some data that STK11 and KEAP1 and even P53 may be associated with less good outcomes, but we're in the situation where it's not all or none. And so you would, I don't think anyone would want to deny this patient the potential of even a small amount of benefit. So this would be a classical chemoimmunotherapy case. I think with Dr. Curran, we have introduced, we've become familiar with the concept of oligometastatic disease. We've become familiar with the concept of oligoprogressive disease. But here we may even have the concept of oligoresidual disease, taking the patient to maximal response with systemic therapy. And then I could go back to Dr. Curran and say, hey, what about now? Some stuff we've had a fantastic response. Do you think there's a role for consolidating it with focused radiation at this point?
Dr. Capmatinib, you mentioned chemo IO, and so that maybe 2 years ago was just one regimen, but there are multiple regimens now. And if this patient were fit, what would be your chemo IO? And would you consider something like the Checkmate 9LA regimen or other chemo IOs outside of Keynote 189, carboplatin, pemetrexed, pembrolizumab? This patient is an adenosquamous. Would that sway you on what you used in this setting?
I think that's a really good point. There are some things that we don't know. So the initial data that squamous patients derive less benefit from pemetrexed also, I believe, included adenosquamous within that. It's a little retrospective. It's hard to know exactly. So the question is here, do we deny the patient the potential for a carboplatin pemetrexed pembrolizumab regime and move to a taxane-based regime? I think in a never smoker, where particularly they have a driver oncogene, honestly, I ignore the squamous element. I have multiple ALK patients with adenosquamous who have responded to pemetrexed. We're preparing that data for publication now. But here, this is a more classical patient, 60 PEC years. Maybe I would use carboplatin, paclitaxel, pembrolizumab. I don't really buy the 9LA. I think that's a regime looking for an indication. So I think I'm going to just go for a classical therapy, probably a non-pemetrexed based regime, and probably with pembrolizumab.
And so, Dr. Kamich, I'm going to steal your scenario and throw it back to Dr. Curran. Let's say Dr. Kamich does start out with 4 cycles of carboplatin, pemetrexed, pembrolizumab, and a very nice response. And we've already radiated. Let's say we've started out radiating the lung already, or we're watching, the brain, or we're watching the brain because it's so small. Dr. Curran, would you think about consolidating with radiation with a good response to initial treatment if what's left over is 3 sites or 4 sites? Is there a role? Does your calculus change after induction has proven the patient? The induction has improved the patient and elicit a meaningful response in the tumor?
Again, a great question, Dr. Levy. On a case-by-case basis, the answer is very probably, definitely probably. And the reason I say that is it's all about the anatomy of where you have to treat and what the risk-benefit ratio is. If this patient's fairly fit, has good pulmonary reserve, the lesions do not require a high dose to a large volume of either lung or other critical structures, yes. If you feel like you're putting the patient at an equal risk of toxicity versus benefit, the answer is no. So it really is a case-by-case basis, but absolutely think that's reasonable in a patient who's otherwise fit and tolerated therapy.
And right back one more time to Dr. Kamich, let's say that radiation is given. Would you then continue the IO post-radiation? Would you continue both the pemetrexed and the IO as maintenance for stage 4, or would you hold off?
I think this is stage 4 disease, and so our expectation of true cure would be hopeful rather than realistic. And therefore, I would keep the systemic therapy going for that which is permitted in the maintenance setting. If it's pemetrexed and pembrolizumab, then I would try and keep both going. If I'd given a taxane-based regime, it would just be the pembrolizumab, which I would keep going.
Okay. So in summary, it sounds like initial recommendation for platinum-doublet plus IO. A consideration from Dr. Curran for consolidative radiation if it's non-critical structures and it's a shared decision-making, followed by, if that's done, a maintenance approach with IO with chemo if using pemetrexed, but IO alone if using taxane.